As you learn to provide prenatal care, you may notice just how complex prenatal genetic testing options are. In fact, ACOG currently has more than 10 practice bulletins and committee opinions directly related to genetic testing. There is a lot of information, important information, to share. We're here to help. Let's break it down. Here are the objectives. Objective 1. Identify who to counsel and why standardization of counseling matters. Objective 2. Recognize the elements contained in a standardized counseling script. Objective 3. Understand available testing options and ACOG recommendations with prenatal genetic testing. Objective 1. Who to counsel and why standardization matters. First and foremost, counseling in a standardized way enables patients to make informed choices. Informed consent empowers our patients and is critical for addressing health disparities. In fact, patients of color have a lower uptake of prenatal genetic testing due to lower rates of informed choice, not negative attitudes about testing. In addition to providing the best care possible for all of our patients, counseling in a standardized way can protect providers from medical legal risk. A recent study conducted in May of 2021 showed that 1 in 5 patients who underwent cell-free DNA screening and half of the patients who underwent carrier screening were unaware that these tests had been performed. We need to do better. ACOG recommends that every pregnant patient be offered genetic carrier screening once in their lifetime and testing for aneuploidy with each pregnancy. Objective 2. What does a good standardized counseling script look like? A good standardized script takes into account that prenatal genetic testing is optional, focuses on patient goals, and clearly lays out the testing options provided in your practice. It includes a discussion of risks, benefits, limitations, and alternatives of those tests. Before ordering a test, discuss costs, how and when results will be shared with the patient, and how data are protected. If your patient is interested in diagnostic testing, carrier screening, or cell-free DNA, it is important to discuss where their genetic data will be stored or used. For instance, some commercial laboratories share genetic data with third parties or may store patient genetic data indefinitely. You should check with the company that your practice uses. Good counseling also involves a discussion of residual risk. It is important to explain to your patients that even after low-risk screening or a negative diagnostic result, there is still a risk of having a pregnancy affected by aneuploidy or another genetic condition. With any high-risk result, it is recommended to involve a genetic counselor. Objective 3. What options are available for prenatal genetic testing? There are a lot of options to review. It's important to keep in mind that all testing is optional and none should be ordered without patient consent. Options can be categorized by screening tests, which tell you a low-risk or high-risk result, and diagnostic tests, which can give a definitive answer for chromosomal abnormalities, and may also be able to tell us about smaller microdeletions and duplications, or known monogenic disorders. This talk will not cover the second trimester anatomy scan, which screens for structural anomalies, but cannot necessarily detect chromosomal abnormalities. We also won't have time to cover pre-implantation genetic testing, or the details of advanced testing like microarray. Let's start by talking about carrier screening. This is a way to determine if a patient carries a recessive allele for a condition for which they have no symptoms. If a patient learns they are a carrier, their partner should be offered testing too in order to predict their risk of having an affected neonate. Carrier screening for a condition should generally be performed once in a patient's lifetime since the patient's DNA does not change with each pregnancy. ACOG recommends that all patients be offered once-lifetime carrier screening for cystic fibrosis and spinal muscular atrophy. Family history or ethnic background may guide additional testing. Let's talk about aneuploidy testing. There are a wide variety of aneuploidy tests available, and no one test is considered the gold standard. It can be hard to keep straight the risks, benefits, and limitations of each. To start, think of tests in 2 discrete groups: screening tests and diagnostic tests. Ultrasound, in particular a nucleotranslucency screen, may be performed in conjunction with other testing options, such as serum screening or cell-free DNA. You should only perform one type of aneuploidy screening at a time. Patients with a high-risk screening test will be referred to a genetic counselor. At that point, they may opt for no additional testing, cell-free DNA if that was not the original test performed, or may move on to diagnostic testing. Remember, some people prefer to start with diagnostic tests. Let's talk more about various screening tests. Remember, these are non-invasive and non-diagnostic, but can predict risk. They include nuchal translucency, which may be performed alone or in conjunction with either serum screening or cell-free DNA. Nuchal translucency is an ultrasound that measures the size of the nuchal fold, which is a normal fluid-filled space that increases with increasing crown rump length. It is typically conducted between weeks 11 and 14. A nuchal fold measuring greater than 3 millimeters or the 99th percentile may predict higher risk of aneuploidy. Other causes of increased nuchal fold measurement include other genetic syndromes, potential cardiac defects, or structural anomalies. Cell-free DNA has become increasingly popular given that it is highly sensitive and specific and can be offered as early as 9 to 10 weeks gestation through full term. It can also predict the sex of the fetus. Cell-free DNA works by sequencing fragments of maternal and placental DNA in the maternal bloodstream and estimates aneuploidy risk by comparing predicted versus measured chromosome fragment ratios. Like all of the aneuploidy testing options listed in this video, cell-free DNA may be offered to all pregnant patients regardless of risk factors. Patients should be informed that this test looks at maternal DNA and rarely may detect maternal mosaicism or malignancy. There are many serum screening test options that do not look at fragments of DNA, but rather at hormones or blood markers to predict risk of aneuploidy. Again, ACOG recommends that patients undergo only one type of serum screening test to avoid conflicting or confusing results. Some of these serum screening options incorporate the results of the NT for increased sensitivity and specificity. We won't go into the nitty-gritty details of each serum screening test, but they are listed here for reference, organized by those tests requiring serum samples at one point in time versus 2 time points. Feel free to pause and review the following tables adapted from the ACOG practice bulletins. Which test is most accurate? Let's talk about detection rate. Generally, for trisomy 21, detection rates are the highest for cell-free DNA testing, around 99%, and lowest for NT testing alone, at 70%. The detection rates for serum screens all fall between these values, ranging from the low 80s to the high 90s. The type of test you ultimately order may depend on what patient insurance will cover or what testing you have available in your practice. Let's start talking about diagnostic testing. Did you know that ACOG recommends that all patients, not just those who are high risk, be offered the option for diagnostic testing during their pregnancy? Some patients choose this option for a definitive diagnosis regarding aneuploidy. Most common diagnostic tests include amniocentesis and chorionic villus sampling. While overall these are safe methods, they do portend a small risk for miscarriage, bleeding, leakage of amniotic fluid, and limb reduction defects. In addition to providing a definitive diagnosis of common aneuploidies, amniocentesis and chorionic villus sampling may provide the opportunity for additional genetic testing, like microarray or testing for monogenic conditions. Amniocentesis involves sampling amniotic fluid with a needle through the abdomen and then getting fetal cells for analysis. It is typically performed between week 16 and week 20. In rare cases, it may be done at any gestational age. There is a risk of rupture of membranes of about 1 in 1,000, which could lead to loss of the pregnancy. Chorionic villus sampling, the diagnostic test in the first trimester, is typically done between weeks 11 and 13 of gestation. Placental villi are obtained through either transcervical or transabdominal access. The risk of loss is about 1 in 300. Every patient has different priorities regarding prenatal genetic testing. It can be helpful to engage your patients in a reflective discussion based on goals of testing to guide your counseling. We hope that this has been a helpful summary to help you counsel your patients about their options for prenatal genetic testing to make an informed decision that is right for them. As new data arise and technology advances, available options and recommendations may evolve. ACOG provides a fantastic resource for up-to-date evidence-based recommendations.